نبدأ؟
اتفضل يا فندم، اتفضل سعد.
اوكي بقى النهارده بالانجلش ولا بالعربي تحبوا؟
لا، هم معظم اللي حاضرين عربي يا فندم.
اوكي خلاص مفيش مشكلة. طيب احنا بالنسبة لنا المهم لينا في الروتيتور كاف تيرز او روتيتور كاف بروبلمز، هي دي المين توبيك بتاعنا النهارده. فاللي احنا بنحاول نوصل له نعرف امتى تو اوبريت، امتى نوت تو اوبريت، امتى تو ريفير البيشنت كويكلي لشولدر سبيشالست او شولدر سيرجنز، امتى وي كان تريت نون اوبراتيف، ولو فيلد كاف ريبير او عيان ما نقدرش نعمل له ريبير للكف، ايه اللي ممكن نعمله as alternative. هنبدأ. ده الاوفر فيو بتاع التوك، انترودكشن. بعدين حضرتك كنت سألتني عن الكارير وازاي الديفلوبمنت في سويسرا، فعملت برضو 2 سلايدز في الاول كانترودكشن، وفي الاخر هيبقى في وقت برضو للناس اللي عاوزه تسأل اسئله. وبعدين ليه كتبت كتب وليه بكتب كتب، ايه الفرق، وبعدين الفاليو بتاع التيم وورك، what is chronic acute, what is the difference في الروتيتور كاف. بعد كده برضو 2 clinical cases عن نشوفهم ازاي ممكن نعمل prevention، ولو chronic cases ايه اللي ممكن نعمل لها. فلو ابتدينا من القاهرة لآرو، المدينة اللي أنا عايش فيها، فهي كانت رحلة يعني مش طويلة قوي بس معتدلة، 22 سنة. فابتديت برضو سنة 2000 دراسة في القصر العيني، ومن بعد القصر العيني actually بعد سنة رابعة توقفت، عملت وقف قيد وسافرت على ألمانيا برلين في جامعة الشاريتيه. دي كانت أول ريسيرش فيلوشيب عملتها، وكانت actually basic research lab work, pipette, PCR, western blot، كلها basic science research على ال closed head injury. It was animal experiments في المايس، في traumatic head injury للمايس. فأنا في 2003 كانت أول مرة عملت أول تريننج في ألمانيا، وكان عجبني جدا الوضع هناك، فقررت إن أنا أسافر وأعمل ريسيرش هناك وأتعلم اللغة الألماني، بحيث إن أنا لما أخلص دراسة أقدر أروح تاني وأبقى متمكن من اللغة الألمانية. بعد كده رجعت مصر، خلصت الجامعة وابتديت عملت حاجة سنة الامتياز في سويسرا. بعد سنة امتياز ابتدت النيابة في مستشفى آرا، ودي اللي كان فيها نيكلاس رينر، كان رئيس ال AO Foundation، يمكن حد منكم سمع عنه أو شافه قبل كده. بعد كده قضيت أول سنتين، بعدين عملت أول clinical fellowship مع ال AO Foundation في زيورخ ديبندورف. بعد ما خلصتها كملت سنتين النيابة، بعدين سافرت البرازيل عشان أعمل التروما فيلوشيب مع ال AO Foundation برضو. بعد ما رجعت عملت الريزيدنسي بروجرام بتاعي في مستشفى الجامعة بزيورخ، وانس انا خلصت ال6 سنين، هم 6 سنين النيابة هنا، سافرت أستراليا سنة ونص علشان الفيلوشيب بتاعت الشولدر والإلبو سيرجري. وبعد ما خلصت رجعت مستشفى الجامعة في بازل، قعدت فيها برضو 3 سنين ككونسلتنت هناك. ومن سنتين ابتديت العيادة الخاصة في آراو وروترست. فده سمري صغير. أنا طبعا كان ليا الشرف إن أتعلم من منتورز كتيرة قوي حوالين العالم، من المايو كلينيك، هارفارد، فلوريدا، كندا، أستراليا، البرازيل، فرنسا، ألمانيا، وسويسرا طبعا. فقدرت أتعلم حاجات مهمة جدا، وكانت من أهم الحاجات اللي الواحد برضو اتعلمها هي who you shouldn't operate on or how to select the patients to operate on. Basically أنت ممكن تعمل عملية لأي حد، بس to get people satisfied we have good results, you have to really good selection of the patients. بالنسبة للكارير والناس اللي بتحب الكارير advising, I did summarize all of that 22 years journey في كتاب اسمه Swiss Made Egyptians، ده available online وعلى أمازون وفي كل البوك ستورز العالمية. لأن في ناس كتيرة كانت بتسألني أنت عملت فيلوشيب إزاي كنت بسافر، وصلت الكونتاكت إزاي، عملت ده إزاي. فعملت الكتاب، و same time عملنا لونشنج للmyfellowship.com، وهي اونلاين بلاتفورم تو كونكت all fellowship providers مع كل الناس اللي بتدور على fellowships، اللي عاوزه تعمل fellowship training to specialize او sub specialize في احد ال specialities. دي كلها حاجات اونلاين available لكل حد. طبعا لما انا ابتديت برضو من سنتين عملت العياده بتاعتي، فكان one of the most important values ليا انه to train the second generation and the new fellows. we created the Swiss Shoulder Fellowship، وعندنا حتى دلوقتي دكتور علاء من هنا معايا برضو هنا 4 شهور. دكتور أمكر الصورة اللي فوق على اليمين كان من الهند برضو، جه عندي من شهر مايو لحد أغسطس خلص. بنتشرف طبعا باستقبال كل الناس. كان عندنا برضو سعادة السفير وائل جاد سفير مصر في سويسرا، جه الافتتاح بتاع العيادة وفيزيتورز من كل الدنيا. الصورة اللي تحت ده رئيس الزمالة بتاع تايوان مع باسم الحسن، مع جي بي وارنر من هارفارد، أليكس ليدرمان من سويسرا، فلوريان جروبهوفر من بالغريست. كل الناس بيجوا يشرفونا في أي وقت، عاوز يجي يتعلم يشوف يقدر يشرفنا في أي وقت. الكتاب الرابع كان كتاب مختلف. الكتب اللي كانت قبل كده كانت dedicated للكوليكس وللسيرجنز وللناس اللي عاوزة تعمل career advising. وبعدين لما بالوقت بصيت في كل الكتب اللي كانت منشورة عن جراحة الكتف، فهي كلها مكتوبة in medical language. ودي كانت المشكلة لما أنا كل البابليكيشن بتاعي لو جيت حاولت أديها لأي عيان مش بيقدر يفهم حاجة منها، لأنها طبعا كلها مكتوب بالميديكال لانجوج. فكان الترانسفير للنولج بتاعت كل التريننج وكل الجيرني دي how to simplify اللانجوج، ازاي نعمل كتاب يقدر يفهمه أي حد general practitioner، مش لازم يكون orthopedic surgeon. ايه الكتاب اللي ممكن يفهمه بتاع العلاج الطبيعي، ايه العلاج اللي ممكن يفهمه العيان شخصيا. اي حد بيشتغل في الميديكال اندستري مش طبيب يقدر يفهم الكونسبتس والمشاكل بتاع الكتف. طبعا في ناس كتير بتعالج ناس بتوع كتف بامراض الكتف و it is more a little bit more complicated، و it is في ناس كتير بيعالجوا كله زي بعضه، والديفرنشيشن هنا مهم قوي الدياجنوزز عشان to have a successful treatment. الكتاب ده برضو جه ونشروا عنه في الجورنال السويسري ان في حد كتب لأول مرة كتاب للعيانين dedicated. لما نبص one of the most important values برضو في الكتاب اللي كنا بنقول عليها patient satisfaction، ان السيرجن is a main point or a main driver، بس it's a whole team to get the patient satisfied. السيرجن is a one part من الهول organization. فاحنا بنقدر بيبقى عندنا العيان، بيبقى عندنا الجي بي جنرال براكتيشنر، الجراح، الاوبريشن سيتر، الامبلانتس، الهوسبيتال ستاف، الكيتشن، العلاج الطبيعي، الانفراستراكشر، الانشورنس طبعا اللي برضه بيدفعوا للحاجات، الادمنستريشن. ففي ناس كتير قوي انفولفد ابتداء بالعيان نفسه انه احنا نعمل له انفورميشن. لما نيجي نفكر هنعالج ولا operate or not operate، لما نشوف الليترشر و randomized control studies مش هنلاقي فيه كتير randomized control studies actually comparing conservative to operative. بس الريفيو ده برضو ورانا 6 من هذه studies وبيوروا ان there is added value، ان احنا بنقلل البين، increase the range of movement، بس still مش كل الحاجات اللي statistical significant are also clinical significant. فلازم برضو نفرق بين ال statistical significance وال clinical significance، لأن احنا الcore value بتاعنا أو المين goal is actually getting the patient better and satisfied. If it's an operation or not, that depends on each case separately. لو بصنا ايه الاوبراتيف اوبشنز اللي available في الليترشر، you have a big wide of variety depending على ال high demand patient، ال low demand patient، ال localization بتاع ال rotator cuff، ايه المشكلة فين، because every single problem has a different treatment. So we'll go step by step through this algorithm to know what we can do. The first case دي supraspinatus stair. بنشوف في الصورة اللي على الشمال ده الالتراساوند. دي حاجة أنا برضو بيوز it in everyday consultation. كل عيان بيجي تقدر very easily, low cost, very quick. In 5 minutes you have the diagnosis, you see the cuff, you see if there is a tear أو لا. On the other side, for the decision making if operable or not operable, then we need the MRI to see the fatty infiltration of the muscle, retraction of the tendon, length of the tendon. دي كلها حاجات to decide upon it for MRI. احنا هنا we do mainly arthrography while doing the MRI. On the down left بنشوف ال intraoperative picture of the cuff, where on the right side how we fix it. This is a speed bridge technique, knotless technique with 4 anchors. لما نيجي نبص تاني على الكيس التانية دي، عندنا واحد ب subscapularis tear on the upper left. بنشوفه في ال MRI. This is one of the cases. There are not much emergencies in the shoulder surgery, but full thickness complete subscapularis tear with retraction مهم جدا ان احنا to treat it quickly او to refer it ل shoulder surgeon. هنا في الشمال بنشوف الريتراكشن which was 1 سنتيمتر، وبعدين لما جه بعدها بشهرين للعيان عملت له ultrasound لانه كان راح للجي بي، والجي بي شاف التير وقال له اوكي we try conservative, we do physiotherapy and see what happens, which most of the cases is okay, but with a complete tear of the subscapularis you shouldn't wait long. ليه؟ لأن اللي بيحصل اللي بنشوفه على الصورة اليمين في الالتراساوند الريتراكشن وصل ل 2 سنتيمتر، ف we have increase of 100% للريتراكشن بتاع التندن. طيب ايه اللي بيحصل لما يحصل ريتراكشن كده؟ لما نبص في الصورة اللي تحت على الشمال ده الفيو from posterior. The dotted lines represent where the cuff should be. The subscapularis on the right side is after repair. But then once you repair it, you do external rotation, internal rotation to see the range of movement and how it's tension على التندون. وهنا نبص ايه اللي يحصل once ان انت you try to remove the tendon retracts through the sutures and it goes back to where it used to be. وده أهم سبب ليه احنا المفروض ما نتأخرش في علاج الكومبليت تير بتاع subscapularis. فاحنا we did again we added one more anchor, we did refix this cuff which could be avoided لو احنا already عملنا له العملية في الوقت المظبوط. Diagnosis is very important in shoulder surgery. There are to get the good therapy you have to have a good diagnosis, and you have to look at it as a puzzle. There are many parts which we put together to get the correct diagnosis, and not every shoulder patient has a cuff tear, not every shoulder patient has an impingement. You hear a lot of impingement, but دي مش الكوز الوحيد للبين في الشولدر. First part طبعا الهيستوري. We have standard forms. Every patient بيجي الكلينيك, they fill these forms, they fill it to every control where they come for the follow-up to know did they improve, فضلوا زي ما هم ولا they get worse, and that's how we take it from one step to the other and decide on changing the strategy بتاعت الثيرابي. ده الامريكان shoulder and elbow score, visual analog score, subjective shoulder value score, and people can draw where the pathology is and decide which hand. During the examination, standard examination as well, we do constant score for every patient we have. We measure the strength for both sides, compare range of movement to both sides, so that you have a good overview of the clinical examination. And we repeat this with every patient, every consultation. For the rotator cuff disease, the most important thing is actually the strength. فهي القوة بتاعة الإيد. It's not pain, it's not range of movement. You can have people with full thickness tear and they are moving normally, and you have people with small cuff tear who cannot move their arm at all. So pain and range of movement are not the indicator. The main indicator is actually the strength. Can they move and have enough strength لما يشيلوا حاجة تقيلة بعيدة عن جسمهم. Cuff tear is also not one cuff or one tendon. It depends. عنده مشكلة في السوبراسبيناتس، عنده مشكلة في الانفراسبيناتس، subscapularis ولا teres minor، ايه range of movement بتاعه، ايه test to every tendon which is different and separately. So when we go through the clinical examination, we test every tendon separately. So first you go and look supraspinatus, you can do Job test, you can do Whipple test, and if it's painful, then actually it is not positive or negative. It should be measuring the strength, and it's not about pain or no pain. So that's very important for deciding on the cuff function. لما نشوف examination بتاع infraspinatus, it is important for the external rotation. So you measure external rotation range of movement and strength in external rotation. That's done in maximal external rotation. Then the leg sign is very important to know if they can hold their arm in the free room or it returns back. Teres minor, if teres minor is also affected, they lose external rotation, and you see it in the hornblower sign for those people who are in 90-degree and can do no external rotation. These have also problem in the teres minor and not only in the infraspinatus. Subscapularis, there is a lift-off test or Gerber test, which shows if they can hold the arm in the room. And the other thing is the modified test where you measure strength and they can push against you. Belly press test also shows if they have good enough strength in subscapularis. Biceps tendon, it is also one of the structures which can cause a lot of pain in the shoulder. So we usually do check into the bicipital groove إذا كان في tenderness في الgroove or not. Palm up test, check if there is pain against pushing in with the elbow flexed or with the elbow stretched. So what usually happens when patient go هنا في سويسرا معظم الناس بتروح الأول للجي بي أو general practitioner، فبيروح هناك بيديله medication non steroidals، بعدين يبعتوا للفيزيوثيرابي، بعدين يرجع تاني للجنرال براكتيشنر يلاقيه لسه متحسنش فيبعتوا للMRI وبعدين يبعتوا للسبيشالست، which is fine in most of the cases. بس في ناس which we need to have a rapid assessment and diagnosis. البيشنت يروح للجنرال براكتيشنر أو يروح directly للسبيشالست. السبيشالست يقدر يعمل medical history, clinical examination, X-ray, and with the ultrasound you can already diagnose 80 to 90% of the pathologies, and you can start therapy directly, or you can call for MRI or CT if required. والprocess ده المodified أو quick bath ده some patients. السلايد اللي جاي أوريكم مين الناس اللي احنا المفروض ما نستناش عليها وقت طويل. الناس اللي عندها مشكلة weakness في السبسكابيلارز especially أو supraspinatus. Also very important الناس دي ممكن يبقى ما عندهاش pain وعندها good range of movement والمشكلة الوحيدة بتاعتها هي السترينث. فدول مهم أوي إن احنا ما نقولش لا ده بيتحرك كويس يبقى ما عندوش rotator cuff pathology. الموضوع مش كده. They can still have a tear, silent tear, وما يقدروش يحركوا بس بيلاحظوا ان هم ما يقدروش يشيلوا حاجة تقيلة بعيدة عن جسمهم يحطها لفوق او لتحت. traumatic cases الناس اللي بيحصل لها تروما حتى لو كبار في السن او shoulder dislocation 60 70 years old او حتى 80 هنا بنشوفهم بيبقوا 80 independent عايشين لوحدهم بيعملوا كل حاجة لوحدهم. They have a shoulder dislocation. They have very high chance إن هم you have complete rotator cuff tear multi-tendon. والناس دي ما ينفعش نقول نستنى عليهم ونشوف هيعملوا ايه. دي ناس لازم نبص عليها بسرعة. طبعا لو حد عمل اكس راي ولقى فيها باثولوجي، او حد كان عمل اوريدي الترا ساوند لقى فيه باثولوجي، او في الام ار اي، الناس دي نعمل لها ريفيرال لحد سبيشالست عشان يبص اذا كان ممكن نعمل حاجه عشان نحسن البين والفانكشن والرينج اوف موفمنت بتاع الناس دي عشان يبقى عندهم سترينث تاني. Once you have the good diagnosis, then you have the treatment. Operate or not operate, it is always the question. بتلاقي عيانين كتيرة، بشوف عيانين كتير بيجوا second opinion third opinion. لما كنت في مصر كان في ناس بتيجي ال fifth opinion، الناس بتحب تلف على دكاترة كتير وتسأل وتتقص. فطبعا ناس كتير انت you can operate anything، كل حاجة تشوفها في ال MRI أو حاجة تشوفها في ال X-ray you can say we do an operation. بس ال whole magic أو ال trick is to have a good selection. في ناس، معظم الناس we don't have time problem to wait and see, and you try the non-conservative treatment first. Most like 2/3 of my patients I treat non-operative and they are very happy and satisfied. فاحنا you have a lot of alternative depending on the diagnosis. Again, if you have a big cuff tear, it's not like a small cuff tear. Bursitis is not the same like arthritis. It always depends on the diagnosis, but we have lots of modalities. We can do steroid injection. We have hyaluronic acid with people with arthritis. You can do PRP or plasma for people with tendinopathy and no tears. So there are lots of modalities. بعضهم بتدفعهم الانشورنس زي الستيرويد، بقية الحاجات هيالورونيك أسيد مثلا أو البلازما دي حاجات ما بتدفعهاش الانشورنس هنا، دي لازم العيانين يدفعوها. في مصر معظم العيانين still have to يدفع بنفسه أو يجيب موافقة بتاعة التأمين. usually لما بعمل انجكشن بتبقى كيناكورت أو كورتيزون 40 ملغ مع بوبيفاكاين 0.5%. لو بنعمل PRP احنا بنستخدم الكيت بتاعت ال ACP which has no medication أو أي حاجة internal. What we do, we take the blood, we put it in the centrifuge, it separates white blood cells from red blood cells. Then you have two separate injections inside each others. وبتقدر بالسرنجة اللي جوانية ناخد بس البلازما ونسيب الريد بلاد سيلز جوه وبننجكت البلازما دي للعيان تاني. Ostenil is one of the products. في products كتيرة للhyaluronic acid which we use with people who has arthritis. Okay, we tried all of the non-operative options, and then people who get operated upon, they get operated, and then still there is a problem. So how do we go further? هو مش طريق سد، احنا لسه we still have options حتى لو كل الحاجات دي فشلت. ايه الديفينيشن بتاع الناس ال irreparable cuff tear، او ايه اللي ما نقدرش نعمل له عملية او ما نقدرش نعمل له عملية simple او repair؟ دول الفاتي infiltration according للجوتا ليج classification زي الصورة اللي على اليمين. لما نلاقي الناس عندهم جوتا ليج classification 3 أو 4 دي ناس contra indicated إن احنا نعمل لها عملية. الناس اللي عندها massive cuff tear bigger than 5 centimeter 2 or more tendons which has لازم نفرق الناس دي acute has an acute tear ولا chronic. People with a chronic multiple tendons retracted fatty infiltrated, there is no way to go, and it makes no sense to go in and repair الcuff حتى لو في still remnants للتندون because it simply مش هتهيل والعيان مش هيتحسن. هنعمله عملية ومش هيبقى مبسوط في الآخر. طبعا برضو أي arthritis أو cranial subluxation للhead البليس ما بنقيس ما بين الأكروميوم والhumeral head إذا كان في space هناك ولا already ما فيش. We have الحمادة classification for which shows the static position of the shoulder أو الهيومرس في الاريا. We do simple X-ray for every patient. أي عيان بيجي حتى لو معاه MRI أو sonography, we still do simple X-rays عشان to show us البوزيشن بتاع الارم. لأن في MRI الناس بتبقى lying down, ما تقدرش really to measure the distance between الacromion and humeral head. فمهم إن احنا نشوف simple X-ray. الارثرايتس it's better to decide on it هنا. الcalcification you see it better on the X-ray. So we have a lot of benefits from the simple, cheap, old version X-ray. Then you need to classify if there is functionally irreparable rotator cuff tears. As we said, fatty infiltration, anything 3 or 4, pseudoparalysis, people who have 2 or more tendon in a chronic fashion, anterior, posterior, or superior subluxation, and arthritis. So having an arthritis in the tendon, in the joint, and then you go and repair the rotator cuff, and then you ask yourself why the patient didn't get better, because these patients will not get better because they have pain due to their arthritis. فدي ناس we have to be aware when we treat them, you shouldn't go and repair their cuff because this is only part of the problem but not the whole problem. Then we move forward. Important, once you know they have a cuff tear which is irreparable, then you decide, okay, where is the problem? Is it problem of the supraspinatus, infraspinatus, the problem of the upper part of subscapularis, of the lower part of the whole subscapularis or teres minor? Because here this is a good paper of Philip Collin and Alex Lederman, which shows the different classifications, and this also takes you back to see, okay, which patient cannot move their arm. And if you look type A, these are people who have a supraspinatus tear and subscapularis tear upper border, and 0% of these patients have pseudoparalysis, which means they cannot move their arm above 90 degrees. In other words, all of patients who has supraspinatus and subscapularis tear, they still can move their arm. So to go back to the point that people who are, they cannot have a cuff tear because there is their arm, it's not true. They can use their arm. But if they have a complete tear of the subscapularis and the supraspinatus combined, which is type B, those are, most of these patients, 80% of these patients cannot move their arm. So pseudoparalysis is a symptom. You just need to interpret it and know what is the reason of that symptom, and then you can decide on the therapy accordingly. Type C, these are have additionally infraspinatus tear, or D, which is supraspinatus, infraspinatus, and E, supra-infra and teres minor. And each of these has a different treatment. So when you look at patients with the posterior superior cuff tear, what are the recommendations? If you look into the literature, actually the evidence covering this topic is all level C, which means it is personal, like case series from opinion leaders, but there is no superiority. If you do a debridement, if you put on a balloon, if you put a graft interposition, partial repair, superior capsule repair, if you do isolated latissimus dorsi to these patients, if you do combined latissimus dorsi transfer with teres minor, if you do latissimus dorsi transfer alone or teres minor alone, they are all more or less similar from the evidence level. So none of these possibilities is superior to the others. And level C is non-randomized trials with historical controls. That's a recommendation grade C, which is level 4 evidence. That's why if you think what is the main factor in decision making, which treatment that patient gets, it's usually where this patient lives. So depend where the patient live, people decide according to their training and what they are used to do to treat them in this fashion. So now I will take you around the world in a journey to see ازاي الناس المختلفة بتفكر بطريقة مختلفة to solve the same problem. If you go لزيوريك لبروفيسور جيربر، هو دلوقتي على المعاش، بس لما كان اشتغل وعنده very lot of studies to support his method، هو أول واحد اللي قال if you have a small cuff tear زي ما هو بيورينا في الصورة، still you can move your head in every direction. So this is not a limiting factor. So لما هو نفسه كان بيعمل fellowship بتاعته مع ألان جيلبر وألان ماسكولا في فرنسا في 1984، كان هو بيشوف العيانين اللي عندهم brachial palsy، بيشوف إن هما ما بيقدروش يرفعوا إيديهم لفوق. وبعدين لما هو فكر إيه ده، أنا برضو لما ببقى في سويسرا بيجي العيانين ساعات برضو ما بيعرفوش يرفعوا إيديهم لفوق كده، فالعيانين الأطفال دول إحنا بنعمل لهم latissimus dorsi transfer. Why don't we do it with the adults؟ طب latissimus dorsi transfer دي بتتعمل إزاي؟ هنا هو بيعمل 2 incisions. الديسكريبشن بتاعه إن واحدة تحت الباط بنفتح أول فتحة which we deliver latissimus dorsi tendon through that opening. كان في الأول بيعمل L-shaped و superiorly delta split و open. دي طبعا steps اللي دلوقتي بنعملها arthroscopic بتاعة الريفكسيشن للكف، فالبارت بتاع الأوبن ده دلوقتي بقى much more developed إن بنعمله arthroscopic. وبعدين you take the latissimus dorsi through a tunnel subdeltoid between the teres major and the deltoid and refix it up to cover the defect from the posterior superior cuff if you have an irreparable supraspinatus and infraspinatus cuff. And now we use it with anchors and do this fixation arthroscopic. But his first description was open in 1984. So if you move upwards to the Mayo Clinic and Rochester to Bassem al-Hassan, now he left. Now he is working in Harvard in Massachusetts. But at that time when he described his technique and I visited him, it was over there in the Mayo Clinic. So he said, okay, we have to go and do 2 incisions, one here. Positioning of the patient is a bit difficult. Propionibacteria are here. Why don't we take the lower trapezius? And he described his technique as well. So he does an opening at the back, just at the spine of the scapula, where you can remove and prepare the trapezius, take it, mobilize it. Trapezius has problems with its length of the tendon. No, مش طويل زي latissimus dorsi. You cannot take it all the way up. So what they do is they do an allograft from the Achilles tendon to elongate that tendon and deliver it the same way as latissimus dorsi and refix it with anchors to solve the same problem. And here you can fix it with a knotless anchor, at least 2 points marking the medial and lateral or anterior and posterior border, and then you connect it to the rest of the cuff side to side to make as much coverage as possible للhumeral head. After fixing it laterally, you go medial and fix it to the lower trapezius. If you go to Boston and visit GB Warner and go a little bit south, north to Ontario and visit George Athwal, or go to Florida, Tampa, and visit Frankel, they, in their hands, when they have patient with this, what they do is mainly the reverse shoulder prosthesis. Reverse shoulder prosthesis, it works by medializing the center of rotation, and through this the delta muscle can take over function بتاع rotator cuff, and you still can move the arm without rotator cuff. If you go to Japan and you see Mohy Taha on the right side and Higgins on the left side, one of the problems in Japan at that time when this technique was described is that they didn't have reverse shoulder arthroplasty. So it wasn't available in Japan. So they had to come up with a technique which could help these patients who have no cuff and still want to have a better function. So Mohy Taha described the superior capsule reconstruction or superior capsule repair, putting a graft to cover the head, but still there is no strength or muscle pulling on that graft. At the time when I was in Sydney and Ben Cass, he thinks, okay, we have a lot of patients from surgery اللي بيبقى عندهم hernia مثلا we do a mesh we do why don't we use the same mesh or a similar one اسمه Rotalock, where you can go through the muscle and then fix that mesh to the head, which can support the cuff. If you go to France and ask Walsh what he does when these patients come to him, and French people and French surgeons usually say biceps is the main cause of pain in the shoulder, so what you simply do, biceps tenotomy, also one of the possibilities to get patients better without big operation. One simple technique, quick, cheap, no anchors, and then they improve in pain and they publish their results as well. Markus Scheibel, at the time he was in Berlin, now he's in Switzerland, but at that time he was thinking, okay, we have, because we don't have anything covering the head, and that head starts hitting the acromion, so what you do is you get impingement, so why don't we do a topiroplasty and remove part of that tuberculum, greater tubercle, so that you can have a little better range of movement without pain. From Israel, there is Senukovich, who developed something called in-space balloon. So that was placeholder in that subacromial space, which gets resolved after about 3 months, and there is a scar tissue. والscar tissue ده هو reduce the pain and lessens that impingement and bursitis, which happens with people who has no cuff. لو رحنا لفرنسا لأنسي لوران لافوس, and we ask him, okay, how do you treat these patients? What he tries is to always repair as much cuff as possible, and then he adds on the in-space balloon to protect that repair which he did to that cuff. So if you come back to Switzerland and visit Jan Loinsinger in Zurich, so what he says, like, okay, we have a cuff, this cuff is weak, we try to repair it, and then نحط عليها extra mesh or patch called pitch patch with like augmentation of that cuff repair. So as you see, there are lots of possible solutions for type D or posterolateral cuff failure or irreparable cuff. If we move to type B or anterosuperior cuff problems, which includes complete tear of the subscapularis with the supraspinatus and they are not repairable, what can we do in such cases? First, diagnosis. At the beginning, subscapularis tear was usually missed by most of the surgeons, and when Professor Gerber introduced his Gerber test and the subscapularis tear as a diagnosis, that was in the American Academy meeting, and then they told them, this is a Swiss disease. We don't have an isolated subscapularis tear here. We don't see these patients. And the problem of that is they get missed, the subscapularis tear. And if you don't go, especially even in the arthroscopy, and search for them and look how the subscapularis looks like and test it and see if it's still attached, you can easily miss a subscapularis tear. That's why also a lot of surgeons say, we never see subscapularis tear, but that doesn't mean that it doesn't exist. It just means that they miss it. So if you don't have a working subscapularis, what you can do is you can do a pectoralis major transfer. You can take the pectoralis major, detach it, and pass it under the conjoined tendon. And that is one of the described methods from Professor Resch من النمسا. وبعدين هنا المشكلة الماسكولوكوتينيوس نيرف. فوي هاف دكتور بروفيسور يوست في سان جالين هنا في سويسرا قال we don't want to miss مع الماسكولوكوتينيوس. We do the transfer but we pass it above the conjoined tendon. And then Basim Al-Hassan came again and said, okay, we actually have the latissimus dorsi and we use it for the posterior superior cuff repairs. Why don't we actually use it in the front to replace the subscapularis? So he detaches the latissimus dorsi through single incision at the front, repairing it from the teres major, and then pass it through and fix it where the subscapularis used to be. So these are the different types of treatment. If you want to go and see, okay, what can we do if we now have posterior superior tear and positive lag sign, which has a teres minor problem, where you have a positive horn blower sign. Also, if you look and test the lag sign, patient can barely do active external rotation, and if you take it passively, move it into the external rotation position and leave it as it is, they cannot hold it in place and the arm retains back. That's important to look for because it has a different therapy than a normal posterior superior cuff repair. In this way, there is Episcopo who described the transfer of combined latissimus dorsi and teres major transfer to solve that problem. Then for the tendon transfer, he describes this in obstetrical paralysis, brachial plexus. That's where he used to do this operation, and now we developed this for the shoulder as well. And that was 2-incision technique. Then came Pascal Boileau and describes this in a single incision technique, taking both, doing a reverse shoulder arthroplasty and adding to it the transfer of latissimus dorsi and teres major. Professor Gerber said, okay, we do 2 incisions, we take only the latissimus dorsi and add it to the reverse shoulder arthroplasty, because reverse shoulder arthroplasty solves the problem of the posterior superior cuff, which is supraspinatus and infraspinatus, but doesn't solve the problem of having the arm in room holding external rotation when you don't have a teres minor. That's why you add on it latissimus dorsi. So if you look at the literature, there's lots of options, and if we try to summarize this and note that everybody looking at this with lots of information and lots of techniques. So how we do this technique, how we can convert it. So what we do it all arthroscopic. We published our technique in Journal of Shoulder and Elbow Surgery. Then we use tapes for the refixation of the cuff or the graft, which we also published, biomechanical study in Journal of Arthroscopy. Then we look at the patient. So there is no one solution fits all. So the first step is to look this patient, if you can do a repair on it. So this is the best option. All of these options, you have to remember, these are salvage procedures for patients where you cannot repair their cuff. So you look at the cartilage. Do they have arthritis or no arthritis? If they have cartilage degeneration or not. So people who don't have arthritis and are Hamada 2 or less, Then you look to the right side. These are people with high demand. So if you have high demand patient who has no arthritis and have irreparable cuff, so you look the anatomy. Is it a posterior superior problem? Is it only the supraspinatus and infraspinatus? If yes, then we do latissimus dorsi transfer. If it's an anterior superior problem where you have the whole subscapularis which is not working well, then we do pectoralis major transfer above the conjoint tendon. If you have combined posterior superior and superior, then we do reverse shoulder arthroplasty. If it's a young patient, then we do a stemless reversed. Then we move further into the middle. These are people who has no arthritis, but they have low demand. And if we say, are they pseudoparalytic, which means they cannot move the arm at all, or they can move their arm, but they have pain and discomfort. So if they just have pain and discomfort and still can move the arm, get above their head, these have pain problem. And pain problem you can treat with debridement plus tenotomy. You can add a balloon or no balloon. There are randomized control studies. There are two randomized control studies. One is just launched this year in Lancet, which says balloon doesn't add value. And there is one launched that was in England, and the one launched in the United States says it has a value and reduces pain. So you can decide. Also, the value and the cost of the balloon is to be considered. If you have low demand patients who are pseudoparalytic, which means they cannot move their arm, then you go for a reverse shoulder arthroplasty. Or patients who has cartilage problem and have arthritis, then you go from the beginning to the reverse shoulder arthroplasty. Then you have to look to, can they hold their arm in external rotation, yes or no? If they can hold it in external rotation, then you do a simple reverse shoulder arthroplasty. If they have a positive lag sign, I cannot hold in external rotation, then you do a reverse shoulder arthroplasty plus latissimus dorsi transfer. So now coming to the end, as we see, I will show you the setup also in our operating theater, how we can now use the mixed reality, how we can use the new technology. We have multiple screens in the operating theater. We can look through the HoloLens. We can live stream the operations. You can have somebody on the online with you to watch the surgery as well. You can have the holograms, the 3D. It's actually like a mobile phone where you can start the app, go for the data, look for the pre-prepared models for the 3D reconstruction. We have also navigation system, which can help us with the navigation and placing each screw in the correct place. You can change it around. You see what I see in my head, and the lens is what you see now on the big screen. And you can live stream in surgery, and you can put it wherever you feel like. It is an added option for you, for people who don't have a navigation system. It doesn't help with navigation, but it helps with the planning, with understanding the 3D anatomy and trying to orient yourself. So in summary, watch out for chronic pain. Chronic pain comes after 3 months already. So you need to special patient refer early or treat early. Then you ask, is there a mechanical cause for that pain? Prevention is the best way of treating of any cuff repair. So we don't want to go to the stage which we have an irreparable cuff. We try to repair the cuff primarily. Many people you can still even treat and make them happy and have a satisfaction without an operation. And if you have a chronic cuff tear, which is irreparable, it's not a dead end. We still have multiple options. And always remember, it is a teamwork. So you need all of the other specialty to support you and help you get your patient satisfied. Thank you.
Thank you so much, Dr. Mohy Taha, for this very interesting presentation حضرتك يعني نقلت لنا different experiences regarding the irreparable rotator cuff tear from different countries, and this is marvelous. شكرا جزيلا يا فندم. انا يعني I have a question for you, sir. You are I know that you are one of the pioneers of using the virtual reality technique in shoulder surgery. In your opinion, what's the main benefit for using virtual reality? Is it the accuracy of the operation or time saving? It reduces the time of operation. What's your opinion, sir?
One of the main values, it's in getting the planning. When you think about the case and you plan it, so you learn the anatomy very well, you understand your case very well. Then instead of doing everything freehand as you think it should be, you can have a support of the mixed reality, which gives you the hologram, and you put it close to the patient, and then you can compare the hologram to the anatomy and try to replicate it by itself. We are not that far that we can use it for navigation. The hardware is not that far, but there are many study groups now working on using the HoloLens or other headsets for to get navigation too. We just published an article, a summary article about the differences between mixed reality, augmented reality, navigation, the benefits and the differences between all of them. It's an open article, so if you just Google Mohy Taha, you will find it. It just appeared 1 week ago.
Yes, sir. Thank you, sir. We have two questions, please, sir. The first question is from one of our colleagues, Dr. Mosmal. In-space balloon gets absorbed after a couple of months. Still, patient gets back the movement. Can you explain this phenomenon, sir?
Yes. So as we said, in-space balloon, it's not about getting the movement. It is not a treatment for people with pseudoparalysis. In-space balloon is a treatment. If you look, maybe I can get the algorithm back. In-space balloon has a value in patients who are this category. People who has dysfunction, which means pain, discomfort, but still they can move their arm. And in that part, you can use in-space balloon. So it's not to regain movement. It is to reduce pain. That's important. And it reduces pain, it makes just a scar, and what we think it does is giving a scar, and then it reduces impingement. But nobody really knows how it does work or why does it achieve. I see a couple of patients who are doing well, but randomized controlled study, they have two different opinions. The English group said it doesn't make a big difference, and the American group said it does make a difference. So you have to test it and decide if you want to do it or not.
Yeah, thank you, sir. Another question, sir. How to choose between lower trap and latissimus dorsi procedures? Any clinical and radiological criteria?
Indication is similar, so either one of them works good. Depends on your training, what can you do. And with the lower trap, you have to know that it needs an allograft. Depends which country, the availability of allograft. It can cost up to $2,000 just for the allograft. Can patient pay it? Is it covered by the insurance? I think these are all conditions and criteria to put in your mind while deciding. Latissimus dorsi is a more demanding operation from the clinical for learning, steeper learning curve, but it's cheaper for the patient, and you just need the anchors to fix the tendon.
Thank you so much. Dr. Mohy, I have the last thing, please, your advice to our colleagues and our attendees, to anyone who's thinking of making postgraduate studies abroad, either in Switzerland or any other countries in Europe, in States. What's your advice to him?
I think the advice is to do enough good research about the country you want to go to. Which country? Because medical system is very different in each and single country. Also the requirements for getting training, recognition of your certificate, do you get accredited or not? Can you do a fellowship program, or you have to start with residency? Which country accept which certificate? So that's important to know in advance. One other thing important is to speak to people who has done this before. If you know persons, or you can go also to our platform, myfellowship.com, and look for people who did a fellowship before, look at their feedback, connect to them, ask them, how was it in that place? So very important is to do enough research and to avoid any frustration when you arrive to that place or country or training program, is to do good research before. If you can visit that center or that country before, speak to the people there, speak to the fellows, decide what if it fits for you or not. It's very important. And I think fellowship training is essential today. If you look at the residence and resident training and resident program, they are getting more and more general. And after finishing the residency, you have seen a lot of cases, a lot of subspecialties. And I think in the past 10 years, we are all moving to subspecialty and doing sports or a joint or arthroplasty. In Europe, we usually do joint. You do shoulder surgery, so you do like all the arthroscopies and arthroplasty in that joint. This is different a little bit than from the States, where people do sports medicine or do arthroplasty, and then when you do arthroplasties, you do hip, knee, and shoulder, and you do sports, you do arthroscopy in all joints. So this always depends on which country you're working in, which country you want to go for your advanced training. And that's why research is important, to understand the system and know how to reach it.
Thank you so much. يعني في نهاية اللقاء احنا مش عايزين نسيب حضرتك يا دكتور محي بصراحة. يعني هو لقاء very interesting. يعني أنا بشكر حضرتك من كل قلبي على حضرتك من وقتك. إن شاء الله
إن شاء الله، وألف شكر على الدعوة دي، وانبسطت جدا إن أكون معاكم النهارده.
شاكر أفضل حضرتك. إن شاء الله نشوف حضراتكم جميعا إن شاء الله مع أحد الطيور المصرية. دكتور محي يعني جود اكزامبل بصراحه. يعني فعلا دكتور محي بيمثل المصري الاصيل، ابن صعيد مصر، ابن مدينه اسوان، اللي يعني ستيل وهو في سويسرا ما نسيش بلده. فيعني احنا طبعا بنسعد برؤيه حضرتك. ان شاء الله برضو احد الطيور المصريه المهاجره الاسبوع الجاي بروفيسور وليد قشطه، رئيس قسم العظام في جامعه ماكماستر في كندا، هيكون معانا. بروفيسور وليد من الناس اللي زي الدكتور محي كده، هم يعني immigrants ولكنهم ستيل يعني بيحملوا حب مصر في قلوبهم. فان شاء الله يعني احنا شاكرين لحضرتك دكتور محي، ونسعد برؤيه الدكتور وليد الاسبوع الجاي ان شاء الله. شكرا جزيلا دكتور محي.
بروفيسور محمد، والف شكر على الدعوه اللطيفه دي. اشوفكم على خير.
شكرا جزيلا يا فندم. شكرا جزيلا يا فندم. كل عام وحضرتك بخير يا فندم.
مع السلامه.
شكرا يا فندم. مع الف سلامه.